Go.
Hello, I'm Amy McConkey Robbins. I'm so pleased you've joined us today for our Rehabilitation Connect Forum. Organizing committee, myself and Amy Birath, who truly has done the lion's share of the work. We began planning this forum almost 2 years ago, and we had 3 goals: to provide a deeper treatment of topics important to habilitation specialists than is normally given at your symposium, to select topics that you, our Alliance members, told us were of high interest in your practice, and to use a format where each presenting team gave both research findings and clinical implications, supporting an evidence to practice continuum. Let us know in your feedback if you think we achieved these goals. We have 3 outstanding CI teams presenting in 1-hour segments today. There will be short live Q&A after each segment, so please submit your questions. Some will be answered during the Q&A, but in addition, we have a full hour of Continue the Conversation with our speakers, which will be live Zoom discussions in 3 breakout rooms immediately after our 3rd segment. The Zoom link for that is posted on the attendee platform in the conference agenda. I want to express our gratitude to Hearing First for generously supporting this inaugural Continue the Conversation event. And now let me introduce our speakers for session 1 from Hearts for Hearing in Oklahoma City. Carrie Neff is a licensed professional counselor and supervisor. She is endorsed as an infant mental health specialist, rostered in child-parent psychotherapy, and certified in trauma-focused cognitive behavioral therapy. Carrie has worked in settings such as early childhood, community-based school counseling, and supporting families who've experienced domestic violence, trauma, and abuse. Darcy Stowe is a speech-language pathologist and Cert AVT who has more than 15 years of experience working with children with hearing loss and their families. Darcy is the chief of listening and spoken language at Hearts for Hearing, where she oversees the clinical work of a team of dedicated speech-language pathologists who are LSLS or are pursuing that certification. We are indebted to these colleagues for sharing their expertise with us today, and I welcome them.
Hi, my name is Carrie Neff, and I am presenting the research portion of our presentation titled Complexities in Family-Centered Intervention. Just to start off with some disclosures, I'm a full-time employee of Hearts for Hearing in Oklahoma City, Oklahoma. I'm not being compensated by ACI, so there are no non-financial disclosures associated with this course. To start off, I want to talk about what is trauma and define it, so that way we have the same understanding and definition of trauma. So we're defining trauma in this presentation as experiencing or witnessing an event in which one felt endangered and it went beyond what could be controlled. So trauma can affect an individual, family systems, community, even generational and historical. And a lot of times with trauma, it's shaped by our perspectives. This is why 2 people can experience the same event, but have 2 different reactions. We often see trauma in 4 different clusters. Re-experiencing, where they may have feelings or memories popping up over and over again. We can also call these trauma triggers. Avoidance, where we're avoiding people, places, things that remind us of that event. We're dampening of a positive emotion, so we're flat affect or very somber. And we might be hypervigilant or looking around, keeping our guard up. A lot of times people don't think infants and toddlers have traumatic symptoms, but the truth is they do. It just manifests differently based on their developmental stage. So before we talk about how trauma impacts brain development, let's review what a healthy brain development looks like. We know it emerges in the early years. So we know that there is this serve and return action between caregivers and infants. And we call this mirror neurons. So for example, we have a mom smiling at the baby smiles back and coos, and then the mom coos, mirroring the sound that the baby was making. What this does is strengthens the neurons and increases the cognition, social, and emotional capabilities. And so as you can see in my graph, with the typical development, the cognition is really strengthened. However, if there's an unreliable serve and return action, it weakens the brain's ability to create stability within the emotional, social, and cognitive capabilities. So as a result, the brain's having to rewire or adjust. So as you can see in the other triangle, that survival is what's being focused on more when it comes to the brain development when trauma is impacting it. And the reason why this happens is because the brain builds from the bottom up. We start with the brainstem. We know it develops in the womb, and then for infants, it controls what the infants can do. It's sending signals to the bodies to let out different cries when the baby is hungry or needing changed or cuddled. It's that survival mode. Next, we have the limbic system. This is where emotional development starts to take place. And within the limbic system, we have the amygdala, the fear center. And this is really developed through early exploration. It shapes the perspective of how the child views the world. It lets them know what is not only physically safe, but also emotionally safe. Next, we have the prefrontal cortex. I call this the thinking part of the brain. What this does is it allows the infants and toddlers to problem solve and understand social skills. It's where the thinking and learning happens. You'll often find that 2-year-olds will have that verbal explosion, and that's because they're utilizing the prefrontal cortex more, because they're using abstract language and speech. What happens though with trauma is they're not able to utilize that prefrontal cortex. And so we're seeing more of the limbic system and the brainstem being utilized more when trauma impacts the development. So I want to show you guys a video called the Still Face Experiment. This is just a great visual of a caregiver and child doing that serve and return action and what happens when a caregiver is active and unreliable.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm my girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
So the ugly situation is what
Babies,
we call toxic stress. And it's a prolonged activation of the stress response system. So that limbic and brain stem, it's sending this to the rest of our body, this stress response. And most of us have heard of fight, flight, and freeze. So this is what our bodies can do when we're having that toxic stress impact. So I want to talk a little bit about what that looks like in toddlers. So for toddlers, when they're in that fight mode, they tend to perceive routine interactions as potential attacks. So the best offense is a good defense. They're gonna kick, bite, hit first. However, when they might be afraid of showing that anger, like to a parent, they might self-punish instead and maybe bang their head on the floor. Usually with healthy development, that aggressiveness will decline because they're able to use that prefrontal cortex and use those problem-solving skills. But if they don't have that healthy development, that's when we're going to start seeing behavioral problems and that aggressiveness continue. For flight, what we see in toddlers is the averting of eye contact. They're failing to greet, obviously strangers, but also people they know. They go through this roller coaster of emotions until they feel reassured that their parents are sticking around. You can often see this when like a caregiver leaves a child at daycare and that anxiety picks up. And then when the parents come back, they may kind of back away from their parents because they're just not sure if they can trust that their parents are really staying around. So these anxious behaviors, they can continue if they don't have healthy development and support from their caregivers. For freeze, it's kind of difficult to read. Toddlers are expressionless. Their mood is sober. They're not playing with toys, which is not typical because we know toddlers love to play, and they're not engaging with people or peers. And so parents often can be confused because there's usually this sudden emotional collapse and they don't know what was the cause of this meltdown. But that's what toddlers are experiencing is that freeze experience with the toxic stress. So we can't talk about trauma without talking about adverse childhood experiences, or ACEs. Researchers and doctors were starting to notice a trend that individuals who had later in life health problems also had reports of possible child abuse and neglect and household challenges. So what they decided to do is send out a survey to like 15,000 participants, asking them what their health was like and if they had any of these adverse childhood experiences. And what they found out was that almost 2/3 of participants reported at least one ACE, and more than 1 in 5 reported 3 or more ACEs. Furthermore, as they continued to study these ACEs and had adults talk more about their childhood experiences, they also discovered that a lot of them shared that they had learning and behavioral problems in childhood. So often they were struggling with social skills and having positive peer interactions. They also were more likely to be on an IEP or repeat a grade. And then finally, they're noticing that this isn't a centralized issue, that it's more of a global concern, and that they're estimating about more than 1 billion children have experienced an ACE. So kind of in summary, what the ACE research has shown is that as the number of ACEs increase, so does the risk for negative outcomes. So there's this cumulative factor that they're noticing. Also, there are biological changes because of that continuous exposure to toxic stress. So there are reports of lack of self-awareness, impulse control, not being able to show empathy. So these biological changes are passing from generation to generation, but also unhealthy coping strategies are being passed from generation to generation. So this then kind of allows doctors and researchers to recognize conditions that could put families and children at risk of ACEs. And then finally, in summary of these ACEs, they looked at it and realized that it's more of a probability versus a predictability. So just a quick summary of what these ACEs are. They asked participants if they had these 5 different types of abuse and 5 types of family dysfunction. And so as participants were filling it out, the survey out, they would just mark if they had any of these different experiences. And physical abuse was the most common type of childhood experience mentioned by all the participants. Finally, the biggest impact that they noticed ACEs attributed to was that it could lead to early death. A lot of the adults were reporting that in childhood and adolescence, they were engaging in risky behaviors. And as a result of that, they started developing chronic health problems and mental health issues. And oftentimes societal issues correlates with mental health and chronic health problems. And so that was a big breakthrough in researching ACEs, is that it could lead to an early death. So we have to ask ourselves, why is this important for Oklahoma? Or even for where you guys live? Well, for Oklahoma, we rank first in number of children with 4 or more ACEs. So this isn't adults reflecting back on their childhood. These are what children are experiencing now. And so a score of 4 or higher typically is viewed as that tipping point of negative outcomes. The 0 to 3 organization also did a survey, and Oklahoma was the highest among all states in having babies have 2 or more ACEs. So before the age of 3, we're halfway to that tipping point. And then another study found that 32% of children in Oklahoma is reported to have 2 or more ACEs. So the families and the children coming into our clinic, the probability of them having experienced a traumatic event or one of these ACEs or having exposure to toxic stress is pretty high, and we need to be mindful of that. So the question is, what do we do about it? So we know that despite having high number of ACEs, there are those who have positive developmental outcomes. So as the research continued to dig a little deeper into why this happens, they found 2 key factors, and one was the value of unconditional love, and the other was having routine and rules. And what this did was create a secure base or foundation to have a more positive trajectory in meeting those developmental milestones. It also helped build secure attachments in relationships. So with friends, with romantic partners, with other adults. Furthermore, these factors helped reflect on a person's identity. They tended to have a more positive self-concept, and they had an idea of moral development, what was right and wrong for them. And this then created a power of resiliency for them. So they're able to positively adapt. So it doesn't take away the trauma, it doesn't take away the severity of the adversity they were experiencing, but they were able to adapt positively and modify those resiliency factors. So they were able to find relationships that strengthened their positive self-concept. They were able to find resources that supported them in a positive path. So they call these factors protective and compensatory experiences, or PACEs. So there's this direct experiences. These are with relationships with other people. So having a best friend, having a mentor, volunteering, it allowed people not only to learn how to help others, but also to accept help, which then can lead into having environmental factors that are positive, such as having a hobby. They're able to master a skill and feel good about themselves. Having rules and routines allowed them to know what were healthy boundaries, positive expectations. and it helped decrease anxiety that often is found when there's chaos. They also broke down paces for ages 0 to 5. You'll notice there's kind of a similarity between them, but for this age range, it's more focused on the relationship. So we're talking about a parent providing nurturance to a child who may need their feelings organized, or a parent helping a child foster empathy by labeling what those feelings are, or a parent providing a family outing so that the child can learn and explore, because we know that's how they shape their perspectives of the world. So in infant mental health, we have to look at the relationship between the parent and the caregiver, or I'm sorry, the parent and the child. We can't look at the child themselves. And this is because it's that relationship is what sets that trajectory of whether that child can be successful in overcoming distress. So I just want to show a little bit of this clip between this father and son and how he's able to use their relationship to help build up these paces.
We need to work on that, right? Yes, okay. Did you understand it though? No. Okay. All right. Huh? Oh, not this one. This is the grand finale of it. Yeah, that's the last one. That's what I was wondering. I don't know what they're gonna do next season because they did some stuff this time. Exactly what I was thinking.
All right, so as you're watching these two interact, I hope you're able to see the delight that they're having in this experience. The dad is doing a great job following the lead of the child as the child's babbling. The child, because dad is focused on their conversation, the child's attention span is longer, so he's learning how to focus more. And overall, what this dad is doing is letting his son know that he has an effect on the world. What he says makes a difference. And so this dad is doing a great job building up these protective factors so that when there are times of distress, the child can be resilient and cope and regulate through those times of distress. So again, when we're thinking about infant mental health, we have to study attachment because that's where we see the relationship between a parent and a child. So attachment is found usually about at the 6 months point of a child. That's when they're really able to determine if a parent is able to meet their needs or not. They start to learn whether or not they can trust their caregiver. And when a caregiver is able to meet those emotional needs, they're able to help their infant learn to regulate. And so when those infants are feeling that distress, they know it's tolerable because they know help is coming. However, when trauma plays a role in the relationship, it can result in a mismatch and attunement. So a parent may not be able to read what the baby's behaviors are or what their cues are. And then if this continues, the baby then miscues or hides their needs because they don't feel like the parent is reliable. There are 4 different types of attachment. Due to time, I'm not gonna go down each and every one of them and explain them, but I do want you guys to be aware that the first 3, secure, avoidant, and anxious, these type of attachments can lead to a positive sense of self. The caregiver is able to meet the needs of the child enough to help them learn how to regulate. So even if mismatches do happen, a repair tends to go along with that, and which helps the relationship heal. However, with disorganized attachment styles, often this is when we really see trauma. And this is where we see a weaker parent-child relationship. We have to consider that there is a biological component when we're talking about attachment. Oftentimes, a hormone is released when a mother gives birth to a baby, and it promotes social bonding and trust. Now, any parent who is having intimate interactions with with the infant can still experience this hormone. It can happen during feeding time or just cuddling or playing. So we then are kind of primed to become a part of the infant's environment. What happens though, for example, prenatal exposure to maternal depression, some sort of trauma can get in the way, and it can actually result in biological changes to the stress level of the infant. So when they are born, they're born with a higher level of stress than what may typically be expected. So again, we have to acknowledge that we're hardwired to have this serve and return, this dance between caregivers responding to the cues that are given by the babies. We also have to think of attachment in terms of relationships. So the relationships that a caregiver has with a child lets them know what to expect from other relationships. So when a caregiver provides that secure base for children, they are more confident in going out and exploring and seeing what the world has to offer, because they know when they need to return to have emotional needs met, they know that their parents are there to help them organize their feelings or comfort them if they need it. Oftentimes, what parents are able to do when they are meeting the needs of their child, it can actually influence the social character. So if a caregiver is able to respond quickly when a child's distressed, the child is able to learn how to cope and manage that discomfort. And so their social character may have more tools in their toolbox of knowing how to handle that distress. They may have more pleasures. Whereas if a parent isn't able to meet the needs and that anxiety, that distress continues, their social character can be more anxious because they're not really sure if they can trust other adults to meet their needs. So they tend to have a more anxious social character. When distress is present, this can cause delays in developmental milestones. So a child may not feel confident that they're able to communicate their signals because the parent hasn't responded. And when they're unsure if their ability to communicate their signals, it tends to lead to them not knowing what else to do. And so you might see a delay, for example, in verbal communication or other social signals. So overall, when we kind of look at the research, we have to acknowledge that the families that we work with, they may have social, emotional, and cognitive impairment and disruptive neurodevelopment based off of either the ACEs that they may have experienced or other traumatic events. And so as an agency, we need to think about how can we be trauma informed instead of traditional interventions where we're just giving them a diagnosis and, creating a treatment plan for it. It doesn't necessarily mean that's going to fix the problem. We have to dig deeper, and that's what a trauma-informed intervention does. We're considering social support because we know it's the backbone of prevention and treatment. And also, as we talked about, it's a biological necessity. We know toxic stress and trauma could impact the body. And so we have to consider ways within our clinics to foster these needs. And my colleague, she will talk about how we have started to take that approach and what we're doing so that we can be more trauma informed for our families, because we know they come to our clinic with a lot of different complexities and we want to be able to meet those needs. So thank you for taking the time to listen to my presentation, and I hope you've enjoyed it. Thank you.
Welcome everyone to part 2 of Complexities in Family-Centered Intervention. By now you have heard from the lovely Carrie Neff, who brought us a wealth of knowledge in topics and research and knowledge related to developing a trauma-informed practice. And from this point, we are going to discuss practical application. Here are my disclosures. So from Carrie, we have heard on a variety of topics, including trauma, ACEs, PACEs. I bet that might have been a new one for you. It sure was for me. A healthy brain, attachment, and toxic stress. This lays the framework for us to talk about what we have learned at Hearts for Hearing as an organization about how to apply these significant topics in developing your trauma-informed practice in working with children and families. And our journey began around 2016, just asking ourselves, okay, we have children who have early identification of hearing loss, access to early, appropriately fit hearing technology, and access to quality early intervention services in listening and spoken language. Why do we still have children with less than optimal outcomes? And we began to broaden our focus and look more at the family system as a whole and explore, okay, what are other existing factors that we can look at and possibly pursue maximizing listening and spoken language for children with hearing loss, for all children with hearing loss. And that's when we began the journey of becoming a trauma-informed practice. And Maya Angelou says it best: do the best you can until you know better. And when you know better, do better. So what do we know already about children with hearing loss? We know children who have hearing loss and are from vulnerable home situations are at risk for delays in listening and spoken language development. We also know the listening and spoken language outcomes of children with hearing loss suffer when they are not exposed to a robust audition-based linguistic model during the birth to 3 age period. We also know that children of families with limited resources are less likely to receive adequate exposure to a language-rich listening environment. And we also know severe exposure to parent verbal abuse results in different patterns of white matter tracts in language processing circuits and an increased density in auditory processing regions of the brain. That lays the framework for the beginning of our journey. Now, prior to learning about infant mental health and trauma and ACEs and family dynamics, sometimes when a child isn't making the progress that we expect in intervention, we think about us. We think about, what am I doing wrong? What could I do better? How could I adjust my goals and communication? Or maybe we think, what's wrong with the caregivers? What's wrong with them? And then we learn a little bit about infant mental health and we start to think, is this what it is? But the more trauma-informed we become and learn more and more about how critical the parent-child relationship is in nurturing listening and spoken language development, we begin to see this space. We begin to see the relationship between the caregiver and the child, and we begin to see possibly the baggage that is within that space. So in 2018, we began a pilot program with a local agency to see how could we grow our knowledge base, how can we empower our providers and our interventionists to know more about serving families with a history of trauma or stress or ACEs. And we began this journey with Sunbeam Family Services. It's a local agency that employs several providers who was a natural partner for us because they have a very similar model as far as early intervention and early care for children. The components of our program included, at the very beginning, included trainings and staffings. So we were looking at, would there be an impact to our practice if we learned more and if we were able to take specific children and look at specific children within our practice? And some of the topics in the first year of this pilot program included circle of security, infant and early childhood mental health, red flags for when to report to DHS, self-care for providers, privacy laws, connection rituals, and adverse childhood experiences. And then our staffings, and by that I mean pulling audiologists and our LSL team, which happens to be speech pathologists, together to talk about challenging families and cases out loud. And so you can see there the regimen of our staffings. And I want to move into some of the content from our trainings. And this slide, I believe, is a beautiful synopsis of a change in viewpoint. So through our time in that first year, we learned to maybe stop thinking so much what's wrong with you and learning to think what happened to you. These are some guiding reflection questions that we began to use as an agency. And these tie in so lovely with the information that we received from Carrie Neff, because they take it and help us apply it to our practice. So things to ask: how does hearing loss affect the relationship between a child and a caregiver? How are we considering a parent and child's history of possible ACEs, along with the environmental context of the family, when designing and or delivering services? No two children are alike, no two families are alike, and thus our delivery and the nuances of how we plan our intervention is sometimes very different from family to family. Also, who can I talk to if I'm seeing one or more red flags? Who are the potential partners in the community who can help me hold this case? So I have some lovely slides here pulled together for practical application, but red flags that infant mental health services are needed. And what I mean by that is an infant mental health specialist can be a licensed professional counselor, can be a social worker, much like a listening and spoken language specialist can be a speech pathologist, an educator of the deaf, an audiologist. But this certification as an infant mental health specialist means these professionals are extra equipped in working in early intervention with children and families. So some red flags for me as I look at the family, thinking that we may need to enlist another professional in their care who's an infant mental health specialist, might be these things here. Okay, when I put on my lens and look at the child, these are some other red flags that services could be warranted. And I'm going to read through these with you. Insecure patterns of attachment. And that might look like, you saw this in the still face video with Carrie Neff, but that might look like we're really struggling or we're turning away from the caregiver a lot. We're referencing or anchoring to the provider instead of the caregiver. We have difficulty self-soothing. We have that flight, fight, or freeze response. We're overregulated. Someone might say of an overregulated child, oh, they're just so chill all the time. So they maybe don't have responses that we would expect to be typical for a child that age. Trauma play or developmental delays or significant regression. Red flags for referring to an infant mental health specialist when looking at the parent-child relationship. Inappropriate development expectations. You know, for example of this would be meeting a 4-month-old and the family saying, she really likes mashed potatoes. The parent's needs override the child's needs. Looking at the dance, how is that dance between the parent and the caregiver? Observing that space, or a possible lack of mutual enjoyment or positive engagement. Okay, this was new for me, but looking at red flags for when infant mental health services might be warranted with you. So not only thinking about the child, not only thinking about the caregiver, not only watching them together, but recognizing your own sense of comfort or discomfort, because you have a gifted sense of knowing. And you need to begin to wonder if you feel confused, swept up in the chaos, squirmy, uneasy, frightened, or icky. And some examples of this that you might tell yourself, or you might hear some of your coworkers say is, man, this family keeps me up at night. Or I really dread this appointment. Or I lose sleep over this kid. Or that dad kind of scares me. Okay, so that's one component, looking at red flags within our own practice to know when we need additional professionals as team members for children and families. Another key component of what we learned in that first year of the pilot program is reflective practice. So the ability to take on the perspective of others as we work through meeting families' needs. And we know that reflecting on your personal experiences can help make you make sense of your practice with families. It can help you understand both your internal positive and negative reactions with families. And it's much like the story of the blind man and the elephant. It's a famous Indian fable that tells the story of 6 blind sojourners that come across different parts of the elephant. In turn, each blind man creates his own version of reality from the limited experience or perspective that they have. And you can see from this picture that the one who was up near the ears felt around and say, oh, this must be a fan, versus the man who was down near the leg and said, oh, this must be a tree. Reflective practice is a way of studying our experiences to improve the way we work, and it helps us see more of the elephant. For time's sake, I'm going to skip over the video and let's look at emotional triggers when working with families. So this is looking internally for you as a provider. What are some things that I can reflect on and take notice of? What do triggers feel like in the moment for me? Is there a body sensation I experience? I need to take steps to regulate my mind and body before I intervene. I've heard this referred to as download calm. It's important for us as caregivers to remain calm and download calm by taking deep breaths, by practice grounding in the room, and by bilateral stimulation. So I might tap both of my feet on the floor, or I might tap both of my knees with my fingers while I'm working through a stressful conversation or situation. I need to ask myself, what am I doing or not doing to meet this family's needs? I need to talk to someone else about this. I need to make a plan for when I'm hearing my shark music. And that's the video we skipped over earlier for time's sake. But shark music refers to when you are triggered by a situation or a conversation or some kind of interaction, being able to recognize that that is triggering something negative based on your past life experience, being able to put that away and keep moving professionally with the family. Okay, reflective practice goals. This is from CPP, which is a special training that Carrie has and other infant mental health specialists have, but the website is there if you're interested in more information. But reflective practice goals are having an awareness of your own emotional reactions, an awareness of personal and or cultural biases, and the capacity to recognize and regulate your own strong emotions prior to intervening. So some different stances. It's difficult to think clearly when you are triggered. Engage your frontal lobe before intervening. And when affect is strong, the first affect to regulate is your own. So some more reflection questions that we can ask ourselves in our practice. Is there space within my practice to talk with someone else about my culture and experiences and explore with curiosity how it might be affecting my cases or the families that I work with? What steps do I need to take within my practice to develop a more mindful, reflective stance when considering my work with clients? Okay, let's move quickly into what our staffings looked like in this pilot program. We were very intentional in the structure of the staffings during this time to have a moment of mindfulness, which separates the rest of the day from what we're entering into, that we had the information beforehand, and then the audiologist and the speech pathologist that were partnering for this child with hearing loss were working together. One of them would talk and one of them would be the listening partner. So that it didn't immediately move into discussion, but it moved into information beforehand, observing a conversation about this child and family, and then opening up for discussion from a facilitator, which might be the licensed professional counselor that you have with you. And we noticed at the end of this pilot program, positive changes in our perspective. Man, our eyes were much more open to how trauma affects families, and that those barriers can inhibit speech and language growth when we have some basic life family system needs that need addressed. We had a positive changes in vocabulary. We were able to talk about what happened to families instead of what was wrong with them. We were able to explore in conversations together with a unified voice in developing a trauma-informed practice. And we noticed our collaboration was stronger in exploring creatively treatment plans and solutions for children and families. Okay, so what happened after that? At the end of 2018, we reevaluated, okay, where are we and what are we going to do moving forward? What has worked well in this pilot program and what could we enhance even more? And it was at this point that we realized knowledge is great, but we need more help. Knowledge is great in knowing and recognizing when families are struggling. But again, we as speech pathologists, listening and spoken language specialists, and audiologists are not trained to meet these critical needs that families need. And we pursued adding in reflective consultation as well as our very own patient care therapists on staff. So quickly, our trainings at this point moved to quarterly, and the topics were driven by request, but also observed need. And formal trainings were always followed by application discussions that allowed the knowledge to move toward application, kind of like the format we're doing today. And our staffings became more as needed and with smaller groups of team members, and then large staffing scheduled as needed. But I want to talk a little bit about the formal reflective consultation that we engaged in. So we learned about reflective practice. We were trained in reflective practice during our pilot program. But in 2019, that was a critical transition where we as LSL providers began receiving monthly reflective consultation with someone trained in the field. And it can be referred to as reflective consultation or reflective supervision. And as it says there, it was scheduled monthly with LSL team members and available as needed for audiology team members. And you might ask yourself, why is that? And just practically, when we think about a child diagnosed with hearing loss and the family is pursuing a listening and spoken language outcome for their child, the LSL provider is seeing that family 4 times a month, 2 to 4 times a month. The audiologist that is on that child's team is seeing that child at Hearts for Hearing based on our protocols 4 times a year. So we found ourselves practically, the LSL team members were in deeper relationships with these families. They were in more frequent contact with these families. They were carrying the load of trauma, toxic stress, ACEs with these families. And it was a natural process that we moved into scheduled reflective consultation with LSL team members and as needed with audiology team members. And I'll show you a little bit about those outcomes in a minute. But reflective consultation consists of supporting providers not only in case management, but in carrying the weight and the burden and the heaviness of working with vulnerable families. So helping them get through and process through hard things, which can aid and support in addressing burnout and job satisfaction. And we are helpers by nature, but we can experience compassion fatigue easily by being so heavily involved and engaged with families. And we want to do everything we can to help those families, but it can wear us down. And reflective consultation has been a fabulous method to support and retain quality professionals. And we have done it in two ways. We have done it with an entire team together, but also team members versus supervisors separated out. And that has allowed a lot of freedom and confidentiality in discussions and wonderings and problem solving. And it's been really, really lovely. Okay, last but not least was an addition to our team. So we know a child with hearing loss, the caregivers are the primary language models. They are the facilitators. They are the real MVPs of their child's listening and spoken language growth and journey. And we intuitively know, along with a child with hearing loss, there's an otologist on the team, an audiologist, a listening and spoken language specialist. But guys, this is where we found ourselves still in desperate need. And we last October hired Carrie Neff, who you've met. She's a licensed professional counselor with several endorsements, including infant mental health. And we refer to her in-house as our patient care therapist. And she works with many families in many different ways, either through consultation with the families or consultation with the providers, and a range of services she provides all the way to direct services for patients and families. It has been a game changer in our practice. Okay, let's look at the proof are in the numbers. Let's look at some surveys that we did with our staff prior to any emphasis on trauma-informed practice and up to as of March 2021. So I'm going to show you growth over time, growth prior to any pilot programs, trainings, and then all the way up to March 2021. This one I'll move quickly through, but the JARS, we saw positive change in how staff view themselves in these following 4 categories. And I have listed out overall change, that's that top line. And then I've also listed the listening and spoken language. And what I mean by that is the listening and spoken language providers, their data pulled out and looked at through a microscope compared to the overall change of the entire organization. Okay, job satisfaction. How does the staff view their own job satisfaction within 3 areas? Coworker relations, supervisor relations, and the work itself. Again, you see overall mostly positive growth here, but I want you to take a look at that middle section. This is interesting because I hypothesize that reflective consultation has drastically affected this number because the LSL team has received this direct reflective consultation and helping them carry their load, helping them communicate with their supervisor on challenging cases, and helping just that team synergy grow stronger. Okay, the professional quality of life measure. How does the staff view themselves within these 3 areas? Compassion satisfaction, burnout scale, and secondary traumatic stress scale. And you can see at the bottom what the goal was. We wanted one of those to increase and 2 of those to decrease. And just one thing of note here is that we did see the overall growth in compassion satisfaction declined a little bit organizationally, but for those who received reflective consultation as a part of their practice, we did see that increase. Okay, this is the oh wow slide for me. So how does the staff view the agency? So each staff member answered a series of questions as how they view Hearts for Hearing as a whole, as being trauma informed within 2 areas: supporting staff development, and then also that supervision relationship, feeling supported, and self-care. And this is fascinating to me because basically these numbers show when you give intentional effort toward growing knowledge and growing help for serving families and becoming a trauma-informed practice, we have grown We have grown significantly in these areas. And I think the LSL team, a 20% growth over time in how they feel supported to do their work and how they feel in their supervision relationship is huge. In conclusion, as providers engaging with families of young children, we must become trauma informed. And now that I know better, what's my action plan for doing better? And I want you to really take that to heart today. And please feel free to ask us in the Q&A for more specific details on any of the information we've given you today. And we look forward to seeing you soon.
Wow. Thank you, Carrie, Neff, and Darcy, Stowe. These were eye-opening presentations and very important for us to hear. I want to ask you an opening question, if I may. How can we, LSLs, audiologists, interventionists, initiate what will seem like a difficult conversation for us with families regarding mental health issues?
Great question. I'll try to answer that as best as I can. I think the biggest thing is being genuine with the families and knowing that you are you have that relationship with your families because you've worked with them for a while and you get to know them, so you know how they'll respond and how they'll interact with you. And so that that can really help by just having that strong relationship there with them and just being transparent and genuine. When they know you're coming from a good place, it tends to help facilitate that conversation a little bit better.
Mm-hmm. Thank you.
I can piggyback on that. I think two things. I've learned the word normalize from Carrie and her practice. And I believe we can normalize the conversation that centers around being healthy. Mental health falls into that. So normalizing that as a thing to talk about, a thing to get help with, because it's not a stigma. The professionals and others are here for help in that. That's my first line of thought there. Second line of thought, something we have learned in the last 6 months with Carrie, who I seem to call by her first and last name through that whole presentation. Don't know why, but that is what it is that we can look at it from two different ways. We can provide services such as Carrie's as a Band-Aid for quick fixes for big problems, or we can start having these conversations from the beginning. And I think that helps to normalize when we talk about the challenges of just having a child, but then the challenges that are compounded on top of that from having a child with special needs, having a child diagnosed with hearing loss, and the complexities that come along with that. And normalizing that from the beginning might make those services more accessible and those conversations more natural.
Mm-hmm. Thank you.
We noticed in the comments that somebody said, Andy said, I would anticipate family to family support consultants also would greatly benefit from reflective consultation. What do you think about that, Carrie?
Absolutely. I actually think reflective consultation can benefit any field of profession. It really just lets us take that step back and look at the family from the whole perspective, and lets us know how we respond to our families too, so that we can make sure that we're present in the moment with them. So early childhood programs can do reflective consultation, school teachers, mental health professionals, speech language pathologists. It really, Andy's right, it really does benefit multiple fields.
There was the question about whether there were any screening tools that providers might use to help identify families who suffered ACEs.
Yeah, there actually is an ACE questionnaire that are given to families. So you can just provide that to the families and they can fill it out. So it's literally called ACEs.
Mm-hmm.
So, and then we do use other tools like depression screenings that can help us kind of identify families who may be at risk as well. We're going through that process of being able to know what families may benefit from services.
As we're coming close to the end, I do want to remind our participants that we will have a whole hour that you'll have to discuss with Carrie and Darcy at the end of all these 3 segments. So please know we'll be dealing with other questions or things that come in. Thank you so much for being here for this first segment.
Thank you.